Good morning and welcome to Department of Medicine Grand Rounds. I'm Clay Smith, Chief of the Division of General Internal Medicine, Palliative Medicine, and Medical Education. Our chair, Dr. Williams, is en route to a meeting and plans to join us a bit later. It is my pleasure to introduce Dr. Tracey Henry, who will be giving today's talk. Dr. Henry is an Associate Professor of Medicine at Emory University School of Medicine. She is the Assistant Health Director for the Grady Primary Care Center and Co-Director of the Health Equity Advocacy Policy Track for Emory's GME programs. Her teaching and research interests include healthcare advocacy and policy, integrating behavioral healthcare into primary care, quality improvement in patient safety, and climate and health equity. Dr. Henry earned her medical degree at Georgetown University and her master's of public health from Johns Hopkins University. When I was preparing to introduce her this morning, I also learned that she and I actually went to college together at Tulane University, having both graduated from there in 2005. She completed a health policy fellowship at Georgetown University, where she studied primary care health-related policies, healthcare delivery systems, and alternative payment models. In 2017, she was selected as a Presidential Leadership Scholar, and in 2020, she won the ACP's Walter J. McDonald National Award for Early Career Physicians. This morning, Dr. Henry will be speaking on climate change and health equity, the problems and steps forward. Please join me in giving a very warm welcome to Dr. Tracey Henry.
Thank you so much, Dr. Smith. I really appreciate that warm welcome, and happy to hear that we're both Tulane alums. The blue waves. All right, green waves. All right. So this morning, I'm really excited to be here to discuss climate change and health equity and the problems and steps forward. I would like to begin by prefacing that I've been doing this work for more intently for over probably around the last year, but I do find that in the beginning, sometimes it can feel a little bit overwhelming, and there's so many terms and evolving terminologies. And so in the beginning, I would like to spend a little bit of time sort of refreshing and giving a background of climate change. All right. Disclosures. I am a 2022 Climate and Health Equity Fellow for the Medical Society Consortium on Climate Change. And our objectives this morning are to discuss climate change and its effects on health and health equity, review specific climate change issues as it relates to internal medicine, and then finally describe some efforts internal medicine specialists can employ to mitigate climate change effects for their patient populations and also for our practices. So what is climate change? We hear a lot of climate change, environmental justice, lots of words out there, but climate change itself is a long-term change in the average weather patterns that have come to define our Earth's local, regional, global climates. So you may hear a lot of people say climate change, it affects the food that we eat, the air that we breathe, and also the water that we drink. Climate change also leads to all of these extreme weather events that we've been seeing over the past few years, and even over the past few months. And when we think about climate change, we do have to go further back to the beginning and think about the greenhouse effect. And the greenhouse effect, if you recall, is when sunlight is either absorbed by the Earth's surface, providing heat and energy, and then reflected back into space. And then some of that infrared radiation is then absorbed by greenhouse gases. And so when you hear people say greenhouse gases, we're thinking about carbon dioxide, we're mentioning methane, we're also speaking of nitrous oxide. And then the problem with the greenhouse effect is that when we get too much of the greenhouse gases, they get trapped within the Earth's atmosphere. It warms the Earth, and then that's what causes all of those different altering in the climate balances. And so, a lot of people, I remember thinking when I was in kindergarten and learning about this and in first and second grade, and then it wasn't, fast forward to a few decades later, and I'm thinking about, wow, we're actually in climate change. Climate change is happening right now. It's not a hypothesis. It's not something that we're thinking about or may happen in the near future, but is actually happening now. And warming of our climate system is unequivocal. And since the 1950s, many of the observed changes are unprecedented over decades to the millennia. And so we've already started to see the atmosphere and the ocean, it's warm, snow and ice have diminished. We see the sea levels rise. We see all of the concentrations of the greenhouse gases have also increased. And so, I like to say, dear Earth, it's not you, it's us. And really humans, we are primarily responsible for the recent change in our climate. And if you look at the graph here on the right side, if you look from 1960 all the way up, this goes to about 2015, we're just slowly sort of increasing very almost at some point it's going to go straight up, almost like a hockey stick or the hockey stick phenomenon. But it's definitely us and our green gas emissions and what we're doing to the earth. And carbon dioxide, of note, is the single largest greenhouse gas emission that is emitted by human activity. And so you also hear climate change, you hear global warming. So what is global warming? So again, climate change is that average patterns over time that we're seeing, takes about 30 years, and it's not synonymous with global warming. Global warming is actually the long-term heating of the Earth's atmosphere. And it's the amount of warming that we're seeing in our planet, in our world, that compared to pre-industrial times. And so you may hear me say this quite a bit throughout the presentation. And so when people are saying, and you may have heard about the new laws and things that you're doing locally in your area in Louisville, Kentucky, is that we are comparing warming to pre-industrial times, because we are attributing the global warming to the industrialization, the building, the cutting down of trees, the lack of green space. And so a lot of times, so that 1 degree Celsius, the warming that we're referring everything to is to pre-industrial times. And so that time is between 1850 and 1900. And what we know, based on where we're going now, every decade, the planet is warming by 0.2 degrees Celsius. So again, I just wanted to say that climate change and global warming are not interchangeable. And I do want to pause for a brief moment, language matters and definitions of some key terms, because we are discussing climate change, we're also discussing health equity. And so some key terms we have here: equity versus equality. I know we've all seen these graphs, but I just briefly want to say, equality is everyone getting the same thing, equity getting what you need, and reality is what you see at the bottom, and things that we're seeing now and the disproportionate effects of climate change on Black and Brown communities. But what we really want is liberation, right? We want to remove some of those barriers to equity. And this is definitions from the CDC. We think about health disparities being the differences in outcomes between groups, and also health equity, again, is when everyone. And then again, health equity is when everyone has the opportunity to be as healthy as possible. And when we think about equity, there are differences just like disparities, but they're unjust, they're unfair. But the sad thing about them is that some of these things could have been avoided. And then systemic racism. Those are the rules and policies and practices and customs that were once rooted in law that is built in every level of our society. And then finally, we have environmental versus climate justice. And so I find out a lot of these terminologies kind of confusing because you hear them all the time. Ultimately, environmental justice and climate justice have become interchangeable. Climate justice is a more recent term, but environmental justice is really just the idea that, and this is the definition from the Environmental Protection Agency, is that we want to ensure that all people, regardless of race, national origin, et cetera, are protected from the disproportionate impacts of environmental hazards. And so the way I like to think about it is that it's the way that our built environment has been created and carved up in ways that expose Black and Brown, Indigenous, and other resource poor communities, even in some rural areas, to disproportionately be exposed to certain hazards in the environment. And then climate justice, again, is really just recognizing that climate change disproportionately affects resource poor and historically marginalized populations. And so we're essentially, they're pretty synonymous and are saying the same thing. And so also sort of setting the stage for our discussion today is to think about two landmark agreements that were enacted to tackle climate change and its negative impacts on health. So the first one is actually the Paris Accord Agreement in 2015. This is an international agreement across multiple countries. And then the idea was everyone came together. We had leaders from all the developed countries and basically say we need to reduce our greenhouse gas emissions. We do know that global warming is killing us. It is worsening the effects of our patients and our populations. And so the thought then in 2015 was that if we could just limit global warming to 2 degrees Celsius, I think we'll be okay. But also while thinking about maybe we really should consider 1.5 degrees of global warming. And then they were going to, all the countries said, we're going to get together and we're going to review our commitments every 5 years. And the other groundbreaking or sort of historic thing at that time is that they also said that we should provide financing to other developing countries to help mitigate climate change and strengthen resilience and to enhance abilities to adapt to climate impacts. And that is really important because what we do know is that many of the industrialized countries or developed countries actually have disproportionately contributed to the effects of greenhouse gas emissions and global warming. And then so the countries and populations that were least likely to contribute are mostly affected. And so therefore, as part of the agreement, they said that even since countries like the USA, United States, and China, that they contribute more to the problem, they should also invest in the solutions for developing countries. And then also we had the Intergovernmental Panel on Climate Change, which is a special policy or policy-making committee group of the United Nations. And so they had this special report, and it sort of highlighted some of the same things that they did in the Paris Agreement in 2015, but they took it a little bit further and also said, we've already warmed to 1 degree Celsius. And so why not just go ahead and say, let's just say our goal is 1.5. We've already warmed to 1 degrees above pre-industrial levels. And there are a ton of horrible effects that are going to happen if we aren't more aggressive about this. And so the difference between this particular panel is that they had a little bit more aggressive goals. And in this particular graph here is the global greenhouse gas emissions and warming scenarios. And so if you take a look at the top and the right where it says no climate policies. So this is what could happen if we do nothing, right? And a lot of people may say, well, this is way off in the future, I'm fine now, but really aren't fine now. And we'll discuss a scenario later. But we do care about, our children and our children's children. So we did nothing. The Earth could warm to 4 degrees Celsius in several decades. And, what would be left of us? It would be a lot of people disproportionately affected by these changes. And then at our current policies of what we're doing, we could warm to 2.5 to 2.9 degrees Celsius. But if you look at the bottom, the one all the way green at the bottom is the 1.5 pathway. And so we're hoping that this is our goal, and this will mitigate some of the effects that we're seeing in our patients. And so you may be wondering, so Dr. Henry, what does this really all mean? And maybe how does this translate into dollars? And so if you take a look here at this graph, comparing the risk of the rising temperatures. And so actually the first one is 2 degrees Celsius. If you look at that one in the second column, if we just go status quo of the policies that we have now or keep to the 2 degrees Celsius, we'll have 18% biodiversity loss versus 14%. We will have in droughts like in California and Arizona and Utah and Nevada, over half of, 1.15 billion people are being affected, versus if we aim for 1.5 degrees, almost a billion people are affected. So these are still a lot of people are being affected, and climate change is now and happening and will still affect people, but will affect less people with tighter restrictions and tighter goals. And so that's what we mean by with our current laws and federal guidelines and regulations of aiming for a goal of 1.5 degrees Celsius, because we'll see less effects of the extreme heat, less effects of sea level rising, less floods, less wildfires, et cetera, and less deaths. So where does the US stand in all of this? This is taken from the Environmental Protection Agency's website, and this is 2014, and this is our global emissions. And so United States, actually, we contribute to 15% of the world's global warming or greenhouse gas emissions, versus China at 30%. And then we have the European Union at 9% and India at 7%. And so, what is our responsibility? So there was a study in the Lancet in 2020 by Dr. Hickel. And so he aimed in this particular paper to figure out, all right, so, whose responsibility is it? Who should contribute more? Who should perhaps have a climate credit? Who's someone that we should keep at bay? And so it was very interesting. He developed this equation. So he called it, this is the national responsibility. So what he did in this particular paper is he thought about it from the standpoint of what is our fair share? What is each country's fair share or allowable, for instance, CO2 or greenhouse gas emissions that they can have per country? So what is your fair share? And then he added up all the cumulative emissions over time, since the industrial age, and then divided by different calculations of a national overshoots in different parts in different countries. And so what he came up with was, even though I showed you on the previous slide that China was actually contributing 30% as of 2014, and the USA was coming in at second, the United States actually is number one in overshooters. So according to Dr. Hickel and his particular study, is that even though right now we've sort of started decreasing our greenhouse gas emissions, we're actually still one of the biggest climate contributors over time. And so we're basically, we're climate debtors. And that goes from thinking about our whole cumulative history of the United States and our industrial age. And so that's something to think about, that we have contributed quite a bit to the problem. And so we want to definitely be part of the solution. And then also of note, the healthcare industry is actually one of the largest consumers of energy. And so if the healthcare sector were a country, the healthcare sector itself will be the 5th largest emitter on the planet. So, this is so important that we're having this discussion today, and that we are making time to teach our learners, is because we contribute quite a bit, not only as citizens of the United States, but also as the members of the healthcare field. So what does all of this have to do with health? This is a medical grand rounds. So I'll tell you what it has to do with health. And like many grand rounds, I will use a case presentation. So we have a 50-year-old female with a history of hypertension, HFrEF, unclear respiratory disorder, anxiety, and depression. And so this patient had been admitted twice in the past month with a respiratory infection and once for a panic attack. I would like to call this patient, give patients a name, so I'm going to call her Mary. So Mary is a widower and a mother of 3, and lives near a railroad track in an older home that was built about 40 years ago and along the flood line. She works 2 part-time jobs, one at an industrial plant, and she makes pottery pieces with varnishes for extra money. So she returns to the clinic for a hospital discharge follow-up. So to many of the clinicians, what are the issues? Is this a COPD exacerbation that she's coming back in for? Had she been coming back to the hospital for asthma exacerbation? Is it pneumonia or some other medical cause? And this is how we are trained to think. But what else could be going on? Could this patient, Mary, have mental health disorders from her prior floods? She lives along the flood line. Could it be increased heart rate or anxiety? Since she also lives along a railroad track. And because she lives near a flood line, there may be mold in the home. She's at a higher risk of infectious disease and from vector-borne illnesses, more mosquito-borne illnesses. And then also, she lives near a transportation hub, but unfortunately you can't use it. So she spends quite a bit of time walking sometimes to work because of the high gas prices. And so could it be extreme heat? Maybe she presented with dehydration or intravascular volume depletion, electrolyte abnormalities, kidney function, or kidney failure. And then she lives in an older home, so it could be lead or indoor exposures like old carpet or allergens. So these are all the things we have to think about as well when our patients are coming in, especially with this unknown respiratory disorder and why does it keep flaring up. And, it would be remiss if we're not to not mention the social determinants of health when we're discussing health equity. But with the social determinants of health, those are the conditions in which we are born, live, work, and play. And in simple terms, these are all those non-medical factors that affect our health. And so it's all of these different things that are on the slide: education, economic stability, et cetera. But I would say that's one particular social determinant that's not mentioned on this slide, and that is climate change as a social determinant. And so you may ask, how is climate change a social determinant? Well, I like to use this particular analogy, and this is the iceberg analogy. So what we see every day when the patient comes into our clinic, the patient may come in with COPD or an anxiety, cardiovascular disease, infections, PTSD. So those are the things that we see on the surface. But what lies beneath the surface are all the social impacts on Miss Mary's care, all the economic impacts, the misinformation and the disinformation. Some people say climate change is not real. There really is no global warming. We're not seeing these effects. All the wildfires and deaths we've seen this year, and droughts and water crises and flooding are not because of climate change. And then there are also inequitable policies. And so all of these climate change can worsen health. It can increase healthcare costs. It disproportionately impacts vulnerable communities, and it also exacerbates the effects of the other social determinants of health. And so climate change is inextricably linked to poor health. And further, climate change is also a threat multiplier, meaning it threatens human health by worsening air quality, increasing the burden of climate-sensitive diseases, and increasing food and shelter insecurity, and so forth. And then we also see historically marginalized communities, other data points, and this is also for the Environmental Protection Agency in September 2021. Again, 34% or more of Blacks and Latinos are more likely to live in areas with the highest projected increases in childhood asthma, with 2 degrees of global warming. They're more likely, 23% are more likely to live in extreme temperatures. 26% are more likely to live in more coastal flooding and traffic areas. And so these are all sort of the numbers and data points that lead to the outcomes and demonstrates the effects of climate change disproportionately affecting historically marginalized communities. And then also the other big issue is the capacity to respond to climate threats. And so that's what we mean by, because I know a lot of people ask me, well, climate change, that's affecting all of us. We're all here on this planet. And that's true, but it affects us unequally. And we all don't have the same resilience or the capacity to adapt to the threats of climate change. And so again, climate change and health equity go hand in hand. right? This is the impacts and the change of climate change on human health. And again, we see all of the rising temperatures, we see the increases in CO2 levels, we see increase in allergens, and then we see respiratory disorders. And this slide looks busy, but I boxed out the piece I wanted us to pay attention to. So, I always get questions like, can you walk me through, like, literally how is climate change affecting a patient's health? And I like this particular slide from Lancet in 2015. But, you start off with the greenhouse gas emissions, causes global warming. This is when you get sea level rises. This is when you get change in rainfall patterns. It's extreme temperatures. Then you get heat waves, or in some places you get droughts. And then you get particulate pollution, ozone increase, more inflammation. You breathe in this, and then you get inflammation and respiratory disease. Same thing with cardiovascular disease as well. It causes this inflammation or increase in allostatic load or wear and tear on your bodies. And that way, in that regard, it affects our health. So the next part, or our second learning objective for this morning was, what is climate change's impact on internal medicine? And so, internal medicine really expands a really broad field. And so we see the health effects across the heat-related disorders, the respiratory disorders, vector-borne illnesses, food and water insecurity, and also we see it in mental health disorders. And so specifically in the heat-related disorders, so as the climate continues to warm, some patients may come to the clinic. It may be rashes and cramps and heat stress. They may come with heat stroke. And I think a lot of times we have patients come in. I work with the resource poor population. Many are homeless or underinsured. And then sometimes we're thinking of so many different things in our differential when a patient comes in. And then sometimes we forget to ask, what does this patient do for a living, right? We have to really go back to that social history. Are they a worker? Do they do things outdoors? Are they a postal worker? Are they construction worker? Or, we really have to figure out what are some of those things that are predisposing them to their presentation that day. And then you can also see decline in cognitive function as well with heat-related disorders. This is a paper that was in New England Journal of Medicine in 2019, and it's a new era of climate medicine, addressing heat-triggered renal disease. And basically, this is the chronic kidney disease of unknown origin. And so this was first seen in El Salvador in the early 1900s, and you still see it in Central America, but guess what? We're also seeing that here as we have a lot more extreme heat days in the United States, and lots of people, or a good number of our patients actually do outdoor work, or even just they're outdoors walking because we told them to get more exercise. And so they're doing what they're supposed to do, but they're also suffering the repercussions of being outside in the extreme heat. Then there's also the respiratory disorders, as we've mentioned previously, and then mental health disorders, including PTSD, and a lot of those are connected to natural disasters. Of course, we probably all remember Hurricane Katrina, and there were quite a bit of people who suffered from PTSD, depressions after being displaced to other places. And so extreme heat and weather events, they can change your mood, they can change your behavior disorders. There's a strain on social relationships, relocation, loss of property, personal finances, all of those things can definitely lead to exacerbation of current mental health disorders, or actually be the precipitant of one. And then finally, with vector-borne diseases, we see more infections. We see more, I've seen several sort of encephalitis cases that were caused by some infected mosquitoes. And we've seen that more so in the last 10 or 15 years. And then there's also food security problems and water scarcity. And so we've been seeing a lot of droughts again in California and Texas and Nevada and Utah. And basically with the water drought, there's decreased crops, and it also affects our economy. And so, and also the rise in CO2 concentrations can affect food quality. It decreases its iron, zinc, protein, and other nutrients in crops. And so even though we may not be thinking about all of these things, but actually climate change, really truly is here and affects every sort of facet of our lives. And then this is a nice sort of summary of the high-risk populations that are affected, again, by climate change. You have your children outside, you have low-income communities, you have our elderly adults who have less of reserve, and then also our communities of color. So what can we do? What is our call to action? So I like to say that this is something that we can implement actually in our visits, in our primary care visits, or even when you're meeting a patient on the wards and you're getting their history. And so that's the climate health history. And this is actually from Marshall et al. And this is from 2002. And they actually sort of describe how can you manage adverse environmental health effects. And so I guess they were a bit, I wouldn't say above the curve because they were already doing this 20 years ago. But they describe that while promoting resilience to climate hazards, we really should take the time and ask some of these questions. And so the mnemonic CH2OPD starts with community. Asking your patients, what are their proximity to hazard waste sites or industrial facilities, anything that gives off odors. And then you might be thinking, well, Dr. Henry, they already have a ton of other triage. We're doing the PHQ-9, we're doing so many other things. We're also asking about the social determinants of health. But honestly, a lot of the climate health history is what we're already doing. If you're really trying to get to the crux of what's ailing your patient, you can't quite figure it out. It really always goes back to that social history and figuring out where they live, where do they eat, where do they play, what do they do, all of those things that could affect their health. So, it may sound like something additional, but technically it's not. We all should take a really good social history. And so I like to say that the climate health history is really sort of a part of a nice, robust social history. And so at home, the age of the home, is it greater than 40 years? We had some legislation last year in the state of Georgia where the minimal requirements or the minimal requirements for public health to get involved for lead in homes, especially for that are affecting our children, was actually pretty low, or the minimum was actually still pretty high. So we were actually trying to make it lower so that public health professionals can get in and get involved, because we still see a lot of effects in even our pediatric populations on lead being in the home. And we recently done some renovations, pesticide use, all of these different things can affect a patient and their health. And you can also ask about their personal habits. Is anyone in the home? Do they smoke? Their diet, what's their source of drinking water, the red meat consumption? Are you taking any over-the-counter meds or remedies? And so an example of how to do that, if you go back to our case here with Mary with hypertension and HFrEF, anxiety, respiratory disorder, lives near a railroad track, et cetera, works at an industrial plant. So if we were to do the climate and health history for Mary, she was positive for proximity to industrial facility, and that gives off odors that perhaps may have been led to some of the inflammation or some of the problems or the recurrent asthma exacerbations that Mary is having. Her home is greater than 40 years old. She has an electric stove, and she lives near a railroad track. And her hobbies, she works with varnishes. We know that there's some chemicals in varnishes they're very toxic. So those are some of the things to think about when our patients come in with sort of these weird lab abnormalities and you're not quite sure what could be causing it. And then she lives with someone who smokes. She eats a lot of red meat and canned meats, including fish. And so other things that we can also do in the clinic environment is something called a climate-informed primary care visit. So this is from Dr. Phillips Bourne. This was published in Adolescent Healthcare in 2021. And so they did a lot of screening protocols, including the social determinants of health. And they also looked for health promotion, including health and planetary benefits. So I adapted this similar guideline from Dr. Phillips Bourne for internal medicine. And so then I call this the climate-informed internal medicine. So different components of a clinical encounter. We usually have our screening protocols for depression and cancer and hypertension and diabetes. But again, we can also ask about questions about food and energy security, water source, their housing conditions. And it's especially important if you've seen in the news in Jackson, Mississippi, with the lack of infrastructure in that particular city. And most of the city is actually, the water is very poor, lack of pressure, and they're on a boil alert, and many people are without water. And so in the beginning, before a lot of people were aware of this problem, screening and asking those questions may have helped some of the people who were ill in the beginning. Also health promotion, usually we ask about DASH diet and wellness techniques. We'll tell about the DASH diet and carb control for diabetes, but also, we could do some other health promotion like biking or walking trails, extracurricular outdoor activities for our patients. Anticipatory guidance, for someone who had muscle cramps or chest pain, call 911. But we want to tell our patients, stay hydrated. If they're homeless, that may be more difficult, but if you can help a patient get to a shelter, this is why it's so important in urban cities to have more green spaces. And it's important to make sure that we have places to sort of mitigate some of these urban islands where there's no place to go to sort of seek shelter and be cool and stay hydrated. And then finally, another component in the clinical encounter would be community resource network and referral plans. So usually we refer people to, a specialty, cardiology or rheumatology or endocrinology, but we can also refer for climate care. And we can do that by working with our social workers or transition of care navigators in the hospital and keeping an updated list of resources. What are some community partnerships? We can use our electronic health records. That's what we do in our system, at least for social determinants and other issues where we have a will, and we try to keep those resources updated pretty regularly so that we're not scrambling for them, and then we can leverage technology and minimize our time looking for things and still help our patients and connect them to the resources they need after they leave us in the clinic. And so another thing that we can do as physicians and clinicians is think about the resilience piece. So what is the conceptual framework for resilience? And these are the things that we want to think about for our patients. So resilience, thinking about the decreased vulnerability, but also increased capacity. Remember, we talked about capacity early on. So we know there are some people that are at a climate vulnerable risk, but we want to make sure that we do what we do with the climate informed visit with taking a climate health history to help our patients be more climate resilient. And in the end, we hope that our patients can recover better than before or recover to the pre-event status. And then, so how can physicians contribute to building climate resilience? Well, we can start learning and educating ourselves about climate, community climates in our at-risk populations. And we can, again, assess our patients' risk. We can support policies and programs in our communities. For instance, programs that plant trees or expand the use of cool roofs. And then we can also advocate for new policies in our cities or in our state and local governments that we can increase walking and biking infrastructure and zoning for more urban farming, so to speak. And what else can be done to slow down climate change and protect health? Well, all these things listed here. But definitely, I think the biggest thing is partnering with our communities. And I would, say that, iterate that is really thinking about where we are, where we work, how can we promote sustainable diets and food systems and increase access for food for our patients in the area. So even as doctors, we have a voice. We are still one of the most trusted voices in the community. I think when I look at the Gallup poll, it's nurses followed by doctors. But as clinicians and doctors and nurses, we are, doctors being second, actually, we are a very trusted voice in the community, and legislators listen to us so we can always be advocates for policies for our patients. Another thing, like today, discussing this during grand rounds, is sort of climate change in med ed. And this is from the AAMC in 2019. And at that time, there was a growing number of medical schools that are starting to add climate-related content to their curriculum. And so more people are starting to realize sort of that link between climate change and health. And the biggest thing is by doing that, we'll feel more prepared to get involved, more prepared to advocate for our patients, and more prepared to advocate for our patients in the clinic visit or on wards. And then I like this particular triad of outcomes, and this is a curriculum by Dr. Maxwell, and it was teaching about climate change in med ed, and this was in the journal Public Health Research in 2016. And basically they said they tried to balance sort of the depth of education and breadth of education in public policy, eco health literacy, but also sustainable healthcare, and sort of weaving that in. How can students weave this into what they're doing from a clinical standpoint? But overall, I think we do need sort of longitudinal climate health curricula for all health professionals. And so what I find is when you have things called curricular threads, where you're threading things throughout what you're learning, it's a little bit more palatable, it makes sense. And you give examples as you're learning cardiovascular health or respiratory or infectious disease versus just having one-off courses on climate change and then you forget about it, but really weaving in how climate change affects our patients throughout is more of the way to go. And then so we need it in UME and GME and even in CME. And then other strategies. So there's two other definitions and concepts. So it's adaptation, and basically it's just how do we adapt to the damage that's already happened. So climate change is already happening. It's happening now. We've already warmed to at least 1 degree. How do I adapt to that? And these are extreme heat events. If we realize that something like that can happen, I was in Chicago earlier in June, and it was like 105 outside. And so everyone sort of had that warning to be careful, make sure you don't spend too long outside in the middle of the day, and make sure you can get somewhere where there was cool places inside or air conditioning. And so, an adaptation strategy means warning people like this is happening now, air quality is poor today, or make sure to stay indoors. So those are some of the things that you can do to sort of adapt to what's going on. And another thing you hear about when you hear climate change is called mitigation strategy. So how do we stop further damage? And that's what we want to do by a lot of the policies that a lot of advocates and grassroots folks and doctors are working communities to make sure that we are starting to address climate change and mitigate its long-term effects. And these are just some examples here. And then we are probably all aware that the Inflation Reduction Act of 2022 was passed and signed into law on August 16th. And basically, this will put the United States on a path to roughly 40% emissions cut by 2030. And this is literally the single biggest climate investment in United States history so far. So if we cut emissions by 40% by 2030, we will be at the 1.5 that I kind of harped on early on in the presentation. And so that's the goal. If we all do our part as individuals, if we all do our part as the healthcare sector, if we all do our part as the United States, that we can contribute, since we're one of the largest contributor of global warming. If we do our part, we can cut emissions by 40% by 2030. And then there's a list of things there of the actual provisions in the Inflation Reduction Act that are supposed to basically tackle climate change and help us get to more clean energy solutions. And what I mean by clean energy solutions, it's just mean renewable energy. So clean energy is renewable energy, and renewable energy are those things like water, solar, the wind, things that are that is renewable, things that if they're easily to replace if they're depleted. So how can you green your facility and your hospital, your clinic? Whether you can do that in several of these categories. I won't spend a whole lot of time on this, but this may be things you're doing already, and these are things you can even do at home. But switch to energy efficient light bulbs, turn down the thermostat, upgrade major equipment to more energy efficient models. Make sure you're building, especially when you're building new buildings, that they're insulated well with energy efficient windows. Plug your computers and equipment into power strips and turn off when not in use. The transportation strategies, we've been hearing about this for years, and obviously in big cities, they do a lot of this. They have more efficient working public transportation systems. But these are things we know. So climate solutions are health solutions, and we don't have to really think about it as much because really they're already here. There are so many organizations, there are so many policies by major organized medicine groups that have already sort of written this up and say, these are the things we need to do. We just need to be aware and start doing them and figuring out what can we do. And actually everyone should have a climate health plan, each and every one of us as a strategy. What can I do at home? What can I do in the clinic to make sure that I am reducing my carbon footprint? Could we bike a little bit more? Can we walk a little bit more, use alternative fuel standards? And then again, reducing healthcare, recycling. We could make sure that we're disposing things locally. So some people actually, it's cheaper in some places, they'll come pick it up and they have to drive a lot further, contributing more to the greenhouse gas emissions and more to global warming, because the more that someone has to travel to bring food to you, or travel to bring your mail, or travel to dispose of waste, all of that is contributing. So you want things to be locally and centralized to where you are to mitigate sort of the greenhouse gas emissions and waste. Food. This was something I never really thought a whole lot about, but actually, drinking tap water or buying those filters so that you are not using bottled water, or using your own bottle with you so that you are not using sort of the bottled waters. And then also red meat and consumption actually costs more and also lead to more greenhouse emissions to make. And so you may see in some particular policies recommendations to eat less eat less red meat so that you could contribute less to greenhouse emissions, gas emissions. And so briefly, I was looking this over, that Louisville actually was one of the fastest warming urban heat islands in the United States. And it was like 4.8 degrees Fahrenheit. Was in the top 10 cities in 2014. And so what that means is if it was 85 degrees in the rural area or in a park, it was really 95% in the downtown urban area. 95 degrees Fahrenheit. But what was great is what I noticed, well, before we get to that, first I noticed that there was these zip code differences, which again leads to sort of the equity issue that I mentioned before, that many streets in Louisville on the west side neighborhood lack sufficient street cover, so you don't see a whole lot of trees, or what we call tree canopy, leading to elevated temperatures, versus you may see in Louisville, where there's a lot of trees and greenery and green space and tree canopy. But what I thought was amazing, I was looking at where Louisville stands, is that in April 2020, you guys have a goal to reduce carbon emissions by 80% by 2015. So you were already doing that before the Inflation Reduction Act. And so you already have a climate action plan, which leads Louisville to be a city in 2021, meaning that you have a plan and you're tracking your goals and you're actually doing your part as a city to reduce global warming. And so our organized medicine groups, again, I'm a Climate and Health Equity Fellow for the Medical Society Consortium on Climate and Health. And these are all of the organized medicine groups that are a part of that and have taken the pledge to decarbonize their medical associations. The National Academy of Medicine has also called for the same charge that every organization, also clinics, hospitals, what are you doing to reduce your carbon footprint? The American Medical Association also in June did something similar as well. They adopted a new policy declaring climate change as a public health crisis and that we should all work to limit global warming to 1.5 degrees Celsius. And then the American College of Physicians also had a paper in 2016 on climate change and its effect on health, and one coming out pretty soon on environmental justice. And so we can all do this. We can protect people and the planet. I like this picture here where it says, allow me to have a future. So in summary, climate change is now, it's a public health crisis and a health equity issue. Climate solutions are health solutions and they're already out there. We really don't have to reinvent the wheel. We just have to be personally engaged and to have a sense of responsibility to do what we can to limit our carbon footprint and global warming. It's an internal medicine across multiple organ systems. We can start including a climate history in our current clinical care, but I will say a lot of it is the social history and things we're already doing. And then we also need concerted advocacy efforts. Many are already underway, but we should always support any sort of advocacy efforts that will save our planet. Right, my contact info is here, and healthcare not so easy. Thank you very much.
Thank you so much, Dr. Henry. This is Kim Williams, the Chair of Medicine, and I'm really delighted to have you speak on this topic because I had just done health equity and nutrition last week. So connecting the two, it was wonderful to see your emphasis on the science behind nutrition. And people don't realize that you actually would do better by avoiding red meat than you would driving a hybrid or an electric car. And so the interesting part to me, being in this space for a while, is the disconnect between government policy and the science. That is, you showed that the biggest impact, that 30% red was the red meat, right?
Right.
But when you look at the government policies, they don't talk about it. And that has to do with a lot of industrial influences on Congress. And we all lobby Congress and they do as well. And, you know, Cattlemen's Association is extremely powerful. I wish they worked for me. And so, and I wish they were producing something that was healthy. And so one of the things that I'd like to point out is that we are at the precipice of the Biden administration's going into nutrition health, and hunger conference, which is going to be at the end of September, and getting a lot of recommendations to try to fix some of this stuff. If we don't, you know, what I like to say is that if we want this planet, we have to plan. We have to actually plan what we're going to do, go forward, and take the biggest chunks out of global warming. And that would be, right now, it's nutrition. So thank you so much for pointing that out. And I'm hoping that everyone will be energized to do the lobbying that you're talking about, get with our state legislatures and our Congress members and let them know that we don't want to be the city that's warming up faster than everywhere else.
Yes, that's good. Thank you so much.
All right, everyone. If you have any questions or anything, you can post them in the chat area, or you can obviously unmute and ask. I don't know if Dr. Smith, if you had something you would like to lead off with, or
thank you, Dr. Henry, for an incredible talk. I was really surprised by the statistic you quoted about if the healthcare sector were a country, it would be the 5th largest contributor to climate change. I was just wondering if you could elaborate a bit on how could this possibly be, and what could we be doing better?
Wow, yes. So we are the 5th largest contributor. Well, the healthcare, based on our transportation that I mentioned, the anesthesia as a field, I have a colleague that's a co-fellow with me in this program, and he's doing a project, and I was just so surprised about all the different gases that anesthesia. So his project that contribute to global warming and also contribute to that large impact that we just mentioned. And so, his project is thinking about how can we figure out the different gases and things that we can do to sort of mitigate that effect. But it's transportation, it's the energy that we use in the hospital. Hospitals are always on, right? The lights are always on. Everything is always going. And so, that's energy, there's transportation, it's the different technologies that we're using. And so all of that is contributing to global warming.
Thank you.
All right, anyone else? If you want to, again, you can post it in the chat area. You may be able to see it. We actually did have a comment from Dr. Bishop, Dr. Laura Bishop, that said, "Thank you for such an incredible talk. I appreciated having so many action items presented." Presented in the focus on Louisville. And she brings us up, proud of the work that Dr. Rooney Bhatnagar is doing with the Environment Institute. There's more we can do. And I was going to mention that might be a great collaboration for you with our Dr. Rooney Bhatnagar and our division of, or somewhat new division of environmental medicine and the Environment Institute and the Green Heart Project. And speaking of such, Dr. Natasha DeJarnett, who is actually, I was going to mention her, and I see her and Clara Sears here from that division, mentioned that you guys, it may be great opportunities for collaboration. But real quick, Dr. DeJarnett comments, wonderful presentation. How can physicians become empowered to be stronger advocates? What led you in this space? Also, could you please share more about the Climate Health Equity Fellows Program?
Yes. So what led me into this space, actually, I heard about it through my specialty society, or our specialty society, the American College of Physicians. And I thought about some of my prior history growing up and hearing about some of my family members growing up in places where there was toxic waste, and then later on, there being people with a higher risk of sort of leukemias and cancers in that area. And so when I heard about the program, I thought, oh wow, yeah, that is so true. And the program was an opportunity for me to become more informed, more aware of the issues, and also to learn advocacy around the issue. And so basically I applied and obviously became a fellow. And it's a one-year program, and we meet maybe twice a month almost, and it's very robust, and we're meeting with fellows across the country and multiple specialties. And it's really a great opportunity to learn about climate health equity, how climate health equities affect internal medicine, other specialties, public health, the messaging around climate. So obviously, if I were to go and speak with a legislator, sometimes climate change can be more politically charged name. So I usually say climate health, or sometimes I say climate change or health solutions, or climate action. And I just think about that solutions are here, and you sort of learn the messaging around it. But to become more involved, actually, I think the applications will probably come out later on this year, maybe I guess we're already in September, about October, November. And then I would just simply apply. And it's really a great opportunity. You meet all of the sort of the experts in the field across the country.
All right, we have one more question. And actually, Dr. DeJarnett says, thanks for the shout out and would love to collaborate. And her, and I can send you her email address and Dr. the contact information for her and for the Environment Institute. Dr. Aaron Murphy from Internal Medicine wants to know, I'm curious, how much does wasted product supplies contribute to the negative environmental impact from the health sector?
Yes, it's quite a bit of the waste contributes quite a bit. I don't know the exact number of the waste. Probably to go back and look through some of my graphs. I have quite a few, but it's a good part of it. I would probably say Waste is probably at least 40 or 50%, because we have to do something with our waste. A lot of our waste is toxic, a lot of our waste is fire hazard. So it contributes quite a bit to the to global warming and the greenhouse gas emissions. Because remember, I mentioned the transportation piece is when we're discarding waste from hospitals, we aren't discarding them right around the hospital. Usually it's taken well off somewhere. And so all of that also contributes to the problem as well.
All right. Well, everyone, this is, and like Dr. Murray said, thanks for the wonderful talk. You laid all the groundwork so well, and I'm left feeling inspired and charged to do more. I think everyone is. So I know, Dr. Smith, you've got to get running here in a second, but would you or Dr. Williams have anything you'd like to wrap up with? Or
I defer to Dr. Smith. Thank you.
Yeah, Dr. Henry, just want to thank you again for giving us a great talk. It was really nice to meet you, and I think you've inspired a lot of us.
Thank you. Thank you for having me.
And one last thing before you go, we now have a long-standing tradition of presenting a nice gift to our guest speakers from other institutions, and it's something very Louisville related. So won't be long, you will be getting your very own Louisville Slugger bat from
so
UPS.
Cool.
So congratulations, and thank you for a wonderful talk. And we'll get this taken care of and get this to you soon. And and again, thank you. Outstanding. Thank
you so much.
Thank you. All right, everyone. We will be back next week. We'll let you know what we're doing. Our guest will be, our speaker will be Dr. Keith Miller from surgery, and that will be presented by gastroenterology. So we'll let you know, get all the information, everyone, here soon. So thank you, everyone, and we will see you next week.